Afternoon. Good afternoon, everyone, and welcome to today's webinar session on management strategies for obstructive sleep apnea and snoring. And we have Mr. Amron Hassan, who is the ENT consultant at BHR UT University Hospital, that will be facilitating today's session. Over to you, Mr. Amron.
Hello, good early afternoon. As has kindly been introduced by Bola, I'm Amro Hassan, ENT and sleep surgeon at Queen's Hospital in Romford. And I'm talking today about management strategies for obstructive sleep apnea and snoring. Moving on. So the learning objectives today is, keeping it quite simple, is to identify what is obstructive sleep apnea, how is it graded, to understand the pathophysiology of sleep-disturbed breathing for obstructive sleep apnea and snoring, to appreciate the consequences of untreated obstructive sleep apnea, to understand the contributors to OSA, what brings it on, to assess the patient with sleep-disturbed breathing, and you'll note that I'm using different words here. One is sleep-disturbed breathing and the other is obstructive sleep apnea, because we will assess all patients, but we may not surgically manage other than those with OSA, and to gain an overview of the treatment options available to us. So, obstructive sleep apnea, in essence, it's obstruction of the airway with persistent ventilatory effort. So you're trying to breathe, but the airway is collapsing or obstructing. The soft part of the airway is actually between the tip of the nose and a laryngeal inlet. So obstructive sleep apnea can happen anywhere in that area. It affects a lot of people, 2% of women, 4% of men worldwide. In England, it's approaching 3%, and it's getting worse because we are becoming increasingly obese. It's measured with the Apnea-Hypopnea Index, AHI. And if you have an apneic episode, it does have a definition, and that's stopping breathing totally for 10 seconds or more. Hypopnea is reducing the airflow entering by 50% or more, again for 10 seconds. So apnea, complete cessation; hypopnea, reduced airflow. And it's graded by mild, moderate, or severe. If you have, let me just say, the apnea-hypopnea index is measured in the number of times per hour. So if you're obstructing less than 5 times an hour, that's normal, apparently. From 5 to 15 per hour is termed mild, 15 to 30 moderate, and over 30 events per hour is severe. And we regularly see people obstructing 40, 50, 60, 80, 100 times an hour. And if you just do the maths in your head, that's once every minute there is 10 seconds where you're not breathing. So the pathophysiology, why is it happening? Well, there are two basic physical laws that govern this area, and they are the Bernoulli Principle and Poiseuille's law or equation. In Bernoulli, if you suck in air into your chest, you're going to experience quite significant negative pressure in the narrowest part of that airway. Okay, so if there's an airway narrowing either at the back of your tongue or at the back of your nose, then the negativity in that area becomes quite prominent. Okay, and that can lead to collapse. Poiseuille's equation says that if you've got a longer tube, then there is increased resistance to flow. So if you have a very long neck, like a giraffe or something, even if it is broad and wide with a good radius, the resistance to flow becomes really very, very high. So if you have a long, thin tube, you've got high resistance to flow and increased collapsibility, leading to obstruction. So as I've said, it's from the nose to the laryngeal inlet. Snoring it's on that gradient of sleep-disturbed breathing, starting with snoring, which is turbulence, and increasing to actual total obstruction, apnea. Okay, snoring is about 50% of the population are up to that. And as I've said, it's just on that gradient up to OSA. It can be due to resistance, so for example, a blocked nose, or an anatomical obstruction, again, blocked nose or big tonsils, reduced muscle tone, and let's remember that that not only happens during sleep, but can also happen in patients who have neuromuscular disorders. And let's not forget Downs in that, Downs children, or trisomy 21. Redundant mucosa, so if you've got a lot of tissue that is redundant in your throat, then that will collapse also. And mouth breathers, because it's not your normal way of breathing, so the laminar flow is disturbed. So the consequences of this on the person are that you get disordered sleep patterns, meaning that you're always waking up in the middle, because you're blocking off, you wake up. You fall asleep, you block off, you wake up. And each time, with each one of these disturbances, your brain comes to life. You may not remember it happened, but it did. And as a consequence, hormones are released, steroids are released, and you know, you're not in that sleep mode anymore, and it takes quite a while to get back into it. So you wake up with unrefreshed sleep. You have daytime somnolescence. You have behavioral problems. So in kids, this is quite prominent in the sense that you've got either a very tired child during the day or a hyperactive child. Yes, a hyperactive child is one that has not slept well. In adults, you could get depression. Your work performance can struggle, as can sleep, as can school, of course, and you get relationship disharmony because of the above factors and the snoring. The consequences of this on the body are hypertension, heart attacks, strokes, heart failure, arrhythmias, and type 2 diabetes and obesity. By the way, anyone can stick their hand up or unmute and just ask me any questions anytime. I'm very flexible and amenable to that. On the roads, well, we know that you're 10 times more likely to have a road traffic accident if you have obstructive sleep apnea. Now, I don't know if many of you will remember, but there's a man who fell asleep at the wheel on a motorway, fell off the banking, and crashed into a train and caused quite significant trouble and death to people on that train. So 20% of all motorway accidents are due to sleeping at the wheel. In fact, I think it's closer to 25 now. And the DVLA says that you must stop driving until treated. In fact, your insurance lapses. If you've got obstructive sleep apnea or you're driving tired, it's not manslaughter when you hit that person and they die. It's murder, because you know that you're tired. Car drivers must have a review every 3 years, and lorry and bus drivers a review every year. Conditions associated with obstructive sleep apnea. Well, there's a lot. You can see them there. As an ENT surgeon, my concerns are the nose, the nasopharynx, the mouth, and the larynx. But let's not forget that there's neuromuscular causes such as cerebral palsy, myotonic dystrophia, myasthenia, multiple sclerosis, and the rest as you see them there. With the nose, which is my area, I'm looking at deviated septums or polyposis, nasal polyps, inferior turbinate, enlargement, other septal problems. We're looking at adenoid enlargement in children, tonsils in adults and children, big tongues, which you may see in, or proportionately anyway, in Down syndrome, lipomas, head and neck burns, papilloma, and things like vocal cord paralysis. So how do you diagnose it? Well, it's important to take a history from the patient, but it's also important, if you can, to take a history from the partner, because they'll tell you if that patient sleeps with an open mouth, if they snore more in a particular position, if they sleep on their back all night or on their side all night. So it's important to get that history from the partner. The past medical history is relevant for the neuromuscular stuff, for the diabetes, for the obesity. And we tend to do questionnaires such as the Epworth sleep score, which is scored out of 24. Over 12 means you're tired, over 16 means you're in trouble. The stop-bang questionnaire is something that's used regularly in a pre-anesthetic assessment to see if a patient may have obstructive sleep apnea. And if you score high on that, 5 or more, then you're likely to end up with a sleep study. Clinical examination is important, of course, including flexible nasal endoscopy, which I'll talk about in a moment. Investigations are polysomnography, which again we'll talk about, and sedation nasal endoscopy, which I'm quite big on, and particularly in this country we're quite big on. The clinical presentation. So during the night, what does the patient say they have, or what should you be asking? Well, what's your snoring like? Is it loud? Does it disturb the neighbours? I mean, I had a patient who lived in a block of flats, and she couldn't sleep at night because it was so disturbing to her neighbours. She would sleep during the day to avoid the abuse, the verbal abuse she would get from her neighbours for being so noisy at night. Do you experience apneic episodes? Do you actually stop breathing? Well, they'll say, I wake up choking in the middle of the night. Is that apnea or is that reflux? Again, the partner is useful in this, and so is the investigation. Fragmented sleep. Do you get up to go to the loo? You go to the loo because you're up, but is that what drove you to get up? Or did you have an apneic episode, your brain woke up, and then you thought, oh, hello, I'll go to the toilet? Night sweats. Nocturnal enuresis is the loo. Restlessness, that's tossing and turning a lot. Sleepwalking and hallucinations. And reduced libido. Now, the sleepwalking hallucinations, we all, well, most of us dream, except we're virtually paralyzed when we're dreaming, except for our eyeballs. But if you get woken up in the wrong phase of sleep, then you feel paralyzed, and you can't, you feel that you've woken up in the middle of a potentially nightmare. And at other times, if that mechanism is distorted, you can get the sleepwalking and hallucinations. Daytime, you feel unrefreshed. You're tired during the day. You get headaches, and if you've got low oxygen saturation through the night, I believe that those headaches are quite significant. You've got poor concentration and cognitive impairment, so you're trying to work, but you just really can't get it together. Clinical examination. BMI is a big deal. A BMI of over 25 is considered overweight. Over 30 is considered obese. Unfortunately, the majority of my patients with OSA are well over 30 and definitely in the obese category. Collar size is indicative. A collar size of 16, 17 and over suggests a problem. Sorry, about the BMI. BMI goes hand in hand with sleep-disturbed breathing and obstructive sleep apnea and snoring. And it's not a linear relationship, but it's as good as. So the heavier you are, the more likely you are to snore and experience obstructive sleep apnea. Again, looking at the patient, if they've got a retrognathia, meaning their mandible is retracted, then that can be a point for concern because it can suggest that the tongue is more likely to flop back into the throat. And here is a line. So I usually use a tongue depressor, if you can see my mouse. I use a tongue depressor to place along that red line. And if everything meets the nose, meets the lips, meets the chin, then you're okay. If the nose meets the lip, but the chin is further back, that's an indication of retrognathia. We look at the relative tongue position, and that's in this drawing here on the right-hand side. And we can grade it according to Mallampati. So we've got grade 1, where you can see the whole of the back of the throat. Grade 2, where you've lost a bit of the uvula. Grade 3, where you've lost, you can't see any of the uvula. And grade 4, where you can't see any of the soft palate. So you can just see hard palate. Grade 4 is very rare. Grade 3 and grade 2 is reasonably common in obstructive sleep apnea. You may have redundant mucosa, floppy around your uvula and along uvula itself, which in its own right can cause turbulence in the air, and it's like a little weight on the bottom of your soft palate. And if that's being shaken, then it itself swells up, increases snoring, and can cause that problem with obstructive sleep apnea. Overcrowded oropharynx, I've got a picture for that, as well as the tonsils. If you've got bad teeth, then that causes a problem with getting a mandibular advancement device, which we'll talk about at the moment. So state of dentition is also important. This is tonsilla hypertrophy. This person here has grade 4 tonsils. The tonsil grading is really simple. So if it's a grade 1, you can't really see the tonsils coming out of the pillars. Grade 2, yep, they're over the edge of the pillars. Grade 3, they're getting really close to the uvula. Grade 4, they are almost meeting behind the uvula. And kissing tonsils is where the tonsils touch each other. This is a grade 4, almost kissing. This is pharyngeal overcrowding. Now, although these tonsils themselves are grade 2, if you look here, they're just sticking outside where they should be, so that's grade 2. But you can see lines of mucosa here, and the actual breathing space is really, really narrow. So if you look in your own mouth, hopefully you've got a little bit more space than this fella. Flexible nasendoscopy. Well, what does that give us? Hello, Fahmida. No? Okay. Flexible nasendoscopy. What does that give us? Well, it provides anatomical and mucosal information on the nasal cavity. We can see if there's any big bends in your septum. We can see if you've got remnant adenoids. We can see if you've got big tonsils. But all of this is from behind rather than looking through your mouth. We can also assess the bottom and the back behind the tongue, in the throat behind the tongue. That's the hypopharynx. You can do a Muller's maneuver while you've got the camera in. And that's basically a person blocking their nose and sucking in hard. And by doing that, we increase the negativity within the pharynx and we see which bit of it collapses. As you can see, I've put here, I've underlined suggests level of collapse. And that's because research has shown that it's actually not that indicative of obstructive sleep apnea or even the level of collapse. But it's a tool. I personally don't use it anymore. This is a gentleman, I think he looks American, and he's got the kit on that measures his sleep at night. It's a polysomnography. Poly, because it's lots of different measurements, somno and graph. Okay, so it measures apnea and hypopnea events, which we now know about. The sleeping position, is he lying on his side or on his back? The number of snoring events and how loud they are. But it also measures blood pressure, pulse, oxygen saturation, respiratory effort, as well as ECG, EEG sometimes. We even have a video camera recording patients to see what they're up to at night. Thoracic movements, that's those bands around the gentleman's thorax. Abdominal movements and limb movements, because we know that people with restless legs may have trouble sleeping, but actually it's not necessarily obstructive sleep apnea. This is what a polysomnography looks like, or the readouts from it. And this up here tells you how you're lying. Are you lying on your left side, on your face, on your right side? Are you actually standing up? This guy's standing up at about 1:20 here. And very rarely does he lie on his back. It also tells us the oxygen saturation. Now he's teetering at around 90% here, which is okay. It's a little bit low, but it's okay. Here's the fluctuations in heart rate. And we know that big fluctuations in heart rate and blood pressure can actually lead to ischemic events. We know this from head and neck surgery. The snoring volume, and several other things. Here, for example, is obstructive areas, where how many times he's obstructive and where. And we can see in this patient that he's obstructing for a little while at about 1:45, and we can relate that to his movements, sleep position, and the hypopneas. We can see that this patient is getting a lot more hypopneas than he is actual apneas. So, what if you are not a big fan of if you're not a big fan of flexible nasendoscopies in clinic? Well, the one that I find is more indicative is something called a sleep nasendoscopy or a sedation nasendoscopy. The real word is sedation nasendoscopy because it's not natural sleep. Why? Because we give you propofol. And we give propofol, and some people give a bit of midazolam. Using these agents, we send you off into an anesthetized sleep. As you recover from that anesthetized sleep, we've switched off the lights, we've toned down all the music and the monitor sounds from the anesthetic machines, and we hope that you then wake up or become lighter in a sleep rather than in an anesthetized circumstance or whatever. And we then using a camera, we look and see how things are performing, how your pharynx is shaping up while you're asleep, fake sleep, and which areas collapse and what we can do to make it better. So while you're actually asleep, we lift up your chin and see if that improves your airway. If it does, then we know a mandibular advancement device will work. We then do a jaw thrust. If that works, well, we know that maybe there's a role for surgery here. So we use it to evaluate the site of obstruction and to guide surgical and non-surgical management. I've standardized this, and I've used evidence to support this. I'll come to that in a minute. Okay, so who do we do sleep nasendoscopies for? Well, most people that end up in my obstructive sleep apnea clinic will have a sleep nasendoscopy or a sedation nasendoscopy. We do it for people with moderate to severe obstructive sleep apnea, but even with mild obstructive sleep apnea, if they are really feeling very tired during the day. We do it for people where CPAP compliance is poor. They're not managing their CPAP, so they're going to get all those comorbidities associated with OSA. In CPAP failures, they're just not using it at all. In mandibular advancement splint failures, and remember, you can't use one if you've got a problem with dentition, or if you're claustrophobic, don't like things in your mouth, increased salivation, TMJ dysfunction, lots of pain. We even do it in disruptive and simple snoring in selected cases, being in mild obstructive sleep apnea. This is a gentleman where I show a sleep nasendoscopy or a sedation nasendoscopy. We're just going to go through this. So we go through the nose. Actually, I know where to take this to that works best. Sorry about the rather sketchy video here. So here we are, we're at the back of the nose, and we're looking down at the nasopharynx. It'll adjust in a moment. There we are. So this guy's nasopharynx is sealed, and it's sealed in a circle, okay? He should start to breathe in a minute, and we'll see what happens. Hopefully. And there he is. He started to breathe, but the opening is really small. In most people, it won't be that small, okay? You can see that that's a breathing in, and you can see that's the uvula down there. You'll see it flopping about. Okay, and you can see with you know a bit of imagination, you can see that the uvula actually flops, hits the back wall of the pharynx, and takes up the soft palate with it. These bulges on the side can represent tonsils growing from underneath, or they can represent fat deposited in the soft palate and a surrounding pharyngeal airway. Now we've gone through the soft palate here, and we can now see the tongue base. This is the tongue base. And we can see the epiglottis. And this is the space, the area the patient is breathing through. Now it should look nothing like this. I should have put a normal video on. But you should have a lot more breathing space. You should have not so much tongue in there. The maneuvers that we then do with a chin lift, for example, should turn up any moment now. When you're there, it doesn't feel so bad with all this blurring and moving about. There, no, not quite yet. So what I tend to do is go up to the nose again, do a chin lift, and then go down so that we can see the changes that have happened all the way through the pharynx with the chin lift. So here we are going down. And this time, it may not look it very much, but he's actually got an improved, slightly improved airway with that chin lift, and you could see the vocal cords underneath, which you couldn't see before. Okay, and now we're up again. It's a bit momentary, I'm sorry. And we're going to do a jaw thrust and go down again. Let's see if I can get to that a bit faster. Okay, and this time, actually, I know it's not very clear, but at the top of your screen, there's actually a lot more airway available. It might be a little bit better if we, again, skip through a bit. There. There, I don't know if you can see that, but we've got a huge improvement in our airway now. This is a much bigger than we had to start with. And we've still got a very bulky tongue base. Again, this is not normal. So let's move on. So the way I assess these patients is I use the research that's been done around the world to compile my own operation note. This is my operation note. It has what we found from the sleep study, what we found from the clinical examination, and then what we found from the flexible or sedation nasendoscopy, which is down here. And what we do is we do it at rest, lips sealed, mouth closed, chin lift, jaw thrust. We use several classifications. We use the VOTE, VOTE classification from Eric Karazian from America. We use the PTL TBE. That's from Mr. Veer, who actually works in our department and is tertiary care for obstructive sleep apnea at UCLH. We then produce recommendations. So if you've got problems with your nose, then you do rhinitis therapy, in which case I'll see you in 10 to 12 weeks to give that a chance to work. If it was an anatomical obstruction and you need a tonsillectomy, for example, then I might as well just give you a follow-up in 2 to 4 weeks. There's no point in delay because we already know what the issue is. But you can see here there are many different ways of managing obstructive sleep apnea, which we'll come to. So, our treatment options. First, we've got to treat the comorbidities. We've got to treat the reflux, the obesity. You've got to stop alcohol before bed because that makes you tired. You've got to think about the sedatives you're using, sleeping tablets, antidepressants. You've got to stop smoking because that gives you rhinitis and reduces your oxygen saturation. Treat nasal congestion. If you've got an allergy, deal with that. If it's non-allergic rhinitis, deal with that. And of course, we as ENT would be happy to help. If you've got a blockage because of a deviated septum or hypertrophic turbinates, we've got to do that too. If the sleep study said that you were having obstructive episodes when lying on your back, but not so when lying on your side, then we can have modification of sleep position. And one of those things that helps with that is Phillips night balance or the Zoma device. We'll come to those in a minute. If your soft palate is really floppy, then we can try, this is conservative methods of course, pharyngeal exercises or singing for snorers. If you type that into a Google search, you will find some stuff about it, singing for snorers, and that's myofunctional therapy. And the rationale for that is, when we used to, if you go with this, when we used to live in the jungle, we used to holler and scream at each other all day and shout. But these days, we don't do that. We talk in a nice subdued tone with no one shouting at anyone, really. And so our muscles aren't used. The muscles of the soft palate aren't used. If you look in a mirror and go, ha, 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 you'll see your soft palate rise. And that's the essence of these singing exercises. And that's to make the muscles in your soft palate to strengthen and therefore be less redundant. Okay? You can use devices such as Snoozio, which I'll tell you about in a moment, as well as Phillips night balance or Zoma. And then you can use Cpap, mandibular advancement devices. And if all that doesn't work out so well, then you can come and see me. So here are the non-surgical treatments. This is the Phillips night balance, which is a little device that you wear around your waist. And what that does is every time you turn on your back, it buzzes and wakes you up. You then turn on your side to stop the buzzing. It is said that within 4 to 6 weeks, you are trained like a Pavlov dog to not sleep on your back. And the consequences of that is it may actually treat your obstructive sleep apnea if you've got supine obstructive sleep apnea. With the exercises, as I said, it's ha ha ha, but there's also other exercises. That's called myofunctional therapy, and I've got a small leaflet on that if anyone wants it. This is shark fin, which you attach around your waist and sticks out of your back there, stops you from sleeping on your back once again. It's a little bit less techy than the Phillips night balance, but it's 175 pounds if you've got that. What I tend to tell people to do is to get a bum bag, put some golf balls in it or tennis balls in it and put it on their waist. They can't turn over and lie on their backs with that in their back, and it's only cost you a tenner at the most. This last one here is Snoozio. Now this is an interesting device. It's like a TENS machine for your tongue. You clip it under your tongue for 20 minutes a day, and it gives impulses, electrical impulses to your tongue, strengthening your tongue muscle. You don't wear it while you're asleep. You use it while you're in reading your newspaper or in the car or, I don't know, even at a meeting, if you can, without talking, of course. And it was found over a 6-week period that actually reduced people's snoring by increasing the tone in their muscle. What's going on at the moment is we're seeing what are the long-term effects of this. Does the effect of this carry on, or do you need to use it regularly? And if you need to use it regularly, how often do you need to use it? At the moment, we're looking at about twice a week in the long term. This is a Didgeridoo, made headlines in the BMJ for being something that treats snoring and obstructive sleep apnea at one point, many years ago. What it does is it strengthens your pharyngeal muscles. Cpap. A Cpap is continuous positive pressure to your airway, delivered either through just your nose or a full face mask. Okay? It keeps the pharyngeal airway open, and instead of relying on suction power, as we do for breathing, it pushes the air in, so it's positive airway pressure. The advantage, well, it's the gold standard for obstructive sleep apnea. It is the best, and that's what I tell every patient that I see. 81% of those people that try CPAP say, yes, I want to try it in the long term. Unfortunately, only half of them actually stick with it because of the tangled wires, because it's uncomfortable, because of the leaks, because it's not very romantic to sleep with one of these devices on. Other problems with it, and this is I've met quite recently quite a lot, is people can't take it camping, which has become a fad again, because there's no electricity. So you need rechargeable devices. Those are available, but they're not cheap. And it gives you CPAP rhinitis because dry air going into your nose does tend to do that. You can have it humidified, and I recommend that all CPAP machines are humidified if possible. This is someone wearing a nasal CPAP. Surprisingly, people do become used to it, and some people swear by it. They say, my life has changed so much that I'm quite happy to have this thing on my face rather than have obstructive sleep apnea. Problems with CPAP is air leak. If your anatomy is blocking it off, and I'll show you an example of that in a minute, if your anatomy is blocking off your pharynx, even with positive pressure, you get quite big leaks, and those can be very disruptive because they start squeaking, waking you up. The machine starts to become a lot noisier as well. It gives you the rhinitis, which we've discussed, skin ulceration because of the pressure of the mask on your face, claustrophobia. Lots of people don't like it because of the claustrophobic effect. Aerophagy, I'm not sure how you pronounce that, but that's air ending up in your stomach. So you're pushing air into your lungs, but it goes down through your esophagus and fills your stomach with air. And these people we consider to be CPAP failures, and we look at ways of improving their compliance, possibly through surgery. So if it is a failure, what do you do? Well, you've got to assess the upper airway, manage the rhinitis, and consider nasal surgery if the nose is the problem. A mandibular advancement device may provide some support. Chin strap for snorers, and you have to write for snorers in your search, otherwise you will get moustaches designs. So chin strap for snorers is basically something that keeps your mouth shut, because we know that if your mouth is shut, you will breathe through your nose better and you'll get better laminar flow. We can consider pharyngeal surgery, or we can consider a combination. So quite regularly I'll say to people, have a chin strap and use your CPAP at the same time, or a mandibular advancement device and use your CPAP at the same time. By using these adjuncts, we may reduce CPAP pressures and improve compliance. These are some mandibular advancement devices. There are many, many, many on the market, from £15 boil in the bag ones to having it bespokely made by your dentist at £400 or so. This diagram on the side here, made by Somnogard, who also make this one, describes or shows how, if your mouth is open, your tongue falls back and obstructs your airway. Whereas if you can pull your tongue slightly forward, remember the tongue is attached to the genioglossus is attached to the tubercles at the front of your mandible. If we can bring your mandible forward, then that pulls your tongue forward, opening up your nasal airway. So they're not suitable if mandibular advancement devices, they're not suitable if you've got poor dentition, or you have no teeth, or you've got a TMJ dysfunction, or you're epileptic. The side effects: increased salivation, annoys people a lot. The altered bite can actually cause deviation of your teeth and change your bite. That bite that you've been to smile right to have corrected can be, brought down again, unfortunately, by these devices. And TMJ dysfunction, I've said before. So upper airway surgery. Well, why? Well, it can help resolve the upper airway obstruction. It can improve your upper airway dimensions. It can reduce CPAP pressures. And it can improve your compliance on CPAP. So before I go into surgical options, it's all a bit quiet and I'm the only person doing any talking. So have we got any questions about what we've said so far?
If you've got any question, please unmute yourself or put your hands up and we can unmute you, but you have the opportunity to unmute yourself and ask any question as we go along. Thank you.
And of course, we've got opportunity at the end to also talk and discuss anything you wish. So upper airway surgery. Well, we've said it can help those things, including Cpap compliance. And what we can do is, if the nose is the problem, septoplasty, rhinoplasty, inferior turbinate reduction, get rid of those nasal polyps if they're there, remove the adenoids and tonsils. Remember, in children that's particularly effective. And then we've got very specific surgical interventions related to OSA, which is the uvulopalatopharyngoplasty, which we'll see in a minute, or laser-assisted uvulopalatoplasty, or Ceylon palatoplasty. All these will have examples in the next few slides. Oh, and there's a few more. Midline tongue-based resection, that's with a robot, which we're coming into using. Other treatment options that are non-ENT is bariatric surgery to reduce your BMI, hypoglossal nerve stimulation, which is a direct stimulation of the hypoglossal nerve, resulting in increased tone of the tongue muscle. We can then have skeletal soft tissue procedures under MaxFax, and we'll see some examples of those. And of course, the ultimate treatment for obstructive sleep apnea, tracheostomy. So uvulopalatopharyngoplasty, well, it's designed to improve the airspace in the oropharynx, get rid of floppy bits, and hopefully improve laminar flow a little bit. Okay, it only works at the palate level and not at the tongue base level. Laser assisted has a really good success rate for snoring to start with, but unfortunately is not so good thereafter, and it can regress. I personally don't use laser assisted uvulopalatoplasty anymore. Here is someone being measured up for it. We're looking down like a tonsillectomy view into someone's mouth. That's the uvula, that's the tongue, and this is the soft palate. Okay, and we're measuring so that we can see, that's a marker pen. We're measuring to see how much we're going to cut into the soft palate. And after we've done, what happens is we trim a bit of the uvula and we make incisions into the soft palate on either side. So by doing so, we raise the whole soft palate and we reduce the bulkiness of that uvula. It's usually done with a tonsillectomy as well, so the tonsils here are gone. Radiofrequency surgery. Well, this is the new kid on the block. Having said that, it's been around for a good 10-15 years, but all the same, maybe even more. What radiofrequency does is it scars the tissues, so makes them stiffer. And you can use it in several levels, which we'll come to. It's minimally invasive. It can be done under local anesthetic, although I don't do that. It doesn't really cause that much post-op pain, and it is repeatable, which is great because you can have second and third applications if the first doesn't work quite right. And what it does is it heats up the tissues to about 60 or 70 degrees, which isn't a full burn, but it's denaturation. So you can see the probe. This is on a piece of chicken, and you can see the lesion developing around the center of the probe. It's a form of bipolar. You can put it in the soft palate, making the soft palate shrink up. So here it is. Nice long soft palate, shrunken. So allowing, remember Bernoulli and Poiseuille, with this long soft palate and this narrowness here, you're getting both of those laws coming in, causing restricted flow and increased collapsibility. So by putting the radiofrequency into it, you cause it to flutter less and to shrink and hopefully give you a better airway. It can be done on the tongue base, and as you can see, this tongue base is pushing on the epiglottis and partly obstructing the pharyngeal airway. Here, after application, of course these are all idealistic, after application the tongue goes forward, again giving you a better airway. And here it is in the inferior turbinates, which were quite bulky, and again they've shrunk down to give you more space. I'm using this more and more, by the way, now. And this is radiofrequency being applied to the soft palate. Again, it's an upside down person, so this is the soft palate here, that's the uvula, and that's the probe going into the soft palate. Robotics. The whole world is turning into robotics-based, particularly a lot of surgical interventions are becoming robotics-based. This is the Da Vinci S, which was relatively new. It's now even slimmer than this. I know that's quite a bulky machine. It's now a bit slimmer than this. And we use it to do tongue-based resections and get to those places which are otherwise hard to reach. The reason we can do that is because with instrumentation, you're using something at the end of an instrument to manipulate the tissues, whereas the joints are actually at the end, so you've got a lot more versatility in the way you can move around, and you improve your field quite considerably. So here is a picture of someone that has got a bulky tongue base and an epiglottis almost again obscuring the airway. Here is their lateral view MRI showing the bulky tongue base. That's the back of the tongue, and this is lymphatic tissue really causing very big restriction in the nasal airway. That's the soft palate. Now this technique, transoral robotic surgery for obstructive sleep apnea, is best for localized lymphatic base of tongue obstructions and restrictions, as I've just described. Here is a patient who would probably benefit from tongue base resection using a robot. I'll play the video just to show you how bad it can be. Now here is the tongue base. That's the epiglottis, and the patient's airway is that tiny little hole. In fact, it's so tiny that they're completely obstructing. That epiglottis is causing a trap door effect, which is completely obliterating the airway. So every time this guy falls asleep, they block off, and that's it. They're going to have an AHI of 60, 80, even more, and really they're going to be very tired, and they're going to have quite significant comorbidities as a consequence. That's us coming up a little bit. That's the uvula. We don't need the rest of this video. So laser-assisted, transoral robotic surgery, which is laser-assisted, that's the bottom of the tongue. That's the anesthetic tube going into the airway. And this is the laser outlining the area of the back of the tongue that we're going to take away. And that is it, looking quite burnt, but reduced in bulk. Now, that bulk allows the epiglottis to then sit a little bit flusher onto the back of the tongue, giving you an improved airway. We can also trim the epiglottis, which would have benefited the man in that last video we saw, and this is it happening using the Da Vinci robot. And that's the epiglottis partially resected. You can see that's the edge of the resection. Those are the vocal cords down there, which have come into view, otherwise that epiglottis may have been blocking that view off. And this is what this person looks like, not that particular person, but a person after a transoral robotic surgery. We can see that the epiglottis is now not collapsing anymore. The tongue base is a little bit, you've got the empty part here, which the epiglottis sits in, and there's the airway, nice and clear. Now, I can't say that this would have completely cured his obstructive sleep apnea, but I bet it did him quite a bit of good. So let's get even more invasive and talk about maxfacs. What they do is, if you've got a short jaw or a short maxilla, they will crack those and pull them forward and then plate them. People do heal, though they do stay wired for about 3 weeks and drinking and eating through a straw for that period. But overall, some people are very happy with the effects. And if you've got a very short jaw, this is one of the things that really works for you. Genioglossus advancement. Well, we know that the tongue is stuck to the anterior part of the mandible. We can cut it out with its attachment, pull forward. I don't do these procedures, but maxfacs may still be doing them. But by doing so, you pull the tongue forward. Hyoid advancement. Remember that tall neck? Well, if you attach the hyoid to the laryngeal cartilage or the thyroid cartilage, then potentially it creates a more stable pharynx for you. Hypoglossal nerve stimulation. It's a little device that's put under your skin and fed through to the hypoglossal nerve, which it gives impulses to, which then causes a contraction of the tongue muscle. And again, it's a form of strengthening for the tongue muscle, but also it can be put on while you're asleep. It figures out, it times in with your respiratory cycle, and will trigger to pull your tongue out of your mouth, out of your throat with each breath. Bariatric surgery, we know this is effective, okay, because, well, there's the papers that say it, but if you weigh less, then you've got less pressure from your abdomen pushing onto your chest. That reduces the problems that you could have with hypoventilation, obesity-induced hypoventilation. But we also know that fat is distributed in the pharynx. So if fat is lining the pharynx, it's reducing the diameter. If it's reducing the diameter, then we've got Bernoulli's principle kicking in. The fat is loose and floppy, which means it's more likely to collapse. So if it's more likely to collapse, and you throw in Poiseuille's law, Bernoulli, then you will collapse in the most collapsible area, which will be the area with the most fat in it. So bariatric surgery does work, as does weight loss, of course. Tracheostomy, you can't beat it. It completely bypasses the area which may collapse. It's nearly 100% successful, but you've got a hole in your neck, you've got management of that tracheostomy site, you've got potential large arteries that may be eroded, the innominate artery being there as one of the big issues. You can get chest infections, speech difficulties, and of course it doesn't look nice. So who pays us, or when do we get paid for doing obstructive sleep apnea surgery? Well, it says here that you've got to have failed lifestyle measures. This is the CCG funding for North Central London rather than North East London, but they're all going to be quite similar. So you've got to have failed lifestyle measures. You've got to have tried to reduce your weight and failed. You've got to have tried to stop the smoking, treat the rhinitis and all these things. And beyond that, you must still have obstructive sleep apnea and a sedation nasendoscopy which shows an anatomical problem. That's when we would step in if your AHI is above 5. It can be below 5 if you've got flow limitation. There's really a problem with anatomy, and your Epworth score is over 15, which means you're considerably tired during the day. That's one criteria. You could also have surgery for sleep disturbed breathing, where Cpap is just not appropriate. You're claustrophobic, for example. Or you've failed Cpap because you cannot use it. You keep taking it off your face. You wake up in the middle of the night tangled in the wires or something. It can be used to facilitate compliance. If you've got very high pressures on your Cpap, which we can reduce surgically, then you may be happy to carry on with that Cpap, and a lot of people are. And we can use surgery if we are able to completely resolve the airway obstruction. We do not provide surgery on the NHS for simple snoring. If a patient has significant disruptive snoring, then a psychological assessment could be done to see the impact on that person and their family, and then that may get funding for surgery for snoring rather than obstructive sleep apnea. But it is a different pathway, and it does require quite a few forms. So in conclusion, there is a role for upper airway surgery. The evaluation of the upper airway is essential. My preferred method is drug-induced sedation nasendoscopy or sleep nasendoscopy. Patient selection is, if you want a good outcome from your OSA surgery, you've got to select your patient. Someone with a BMI of over 40, it doesn't matter what you take out. The fat is still there. The hypoventilation is still there. You're not going to do very well. I personally, I'm quite strict about BMI being under 32, unless there's an obvious anatomical problem, preferably under 30. And I'm quite happy to refer you to a dietitian to help with that. We can use combined treatment modalities such as the chin strap and Cpap. We can do multi-level surgery at the soft palate, at the tongue base, even on the jaw itself. We can use surgery and adjuncts such as the mandibular advancement device or chin strap to reduce the Cpap pressure. And finally, and really quite importantly to my practice, is the multidisciplinary approach. We do not work alone. We work with respiratory physicians, psychologists, max facs, bariatrics, dietitians, of course, that comes under bariatrics. Really, we're very careful about assessing the patient as fully as possible and giving them to the right person. So it's not rare for me to find someone who says, I can't sleep, I'm so tired. We do a sleep study for them and they don't have obstructive sleep apnea, or not in proportion to the tiredness. And we do some questionnaires, which I do a lot of, and we find that they're actually insomniacs and they need psychiatric therapy and CBT rather than surgery. So we've got to be careful about not operating on the wrong person. Thank you. Questions if you want.
you. If you've got any questions, please unmute yourself, or if you prefer not to, you can actually put it in the chat box as well. If you've got any question you would like to ask, please kindly kindly unmute yourself or put that in the chat function on Zoom. Thank you.
Stunned silence, eh?
Yeah, of course. Okay. Okay, thank you. Also, I've got some people who were not registered but attended today's session, which is fine. But for me to send you the today's presentation, I will need to know your email address. I know as we're going along, I've been sending private messages to people to kindly let me have their email address. So if you haven't, without your email, unfortunately, I won't be. Let me stop